Ladies and gentlemen, please join us for a discussion about the future of public health. Please join me in welcoming Dr. Rachel Levine, Secretary of the Pennsylvania Department of Health, Dr. LaQuanda Nesbitt, Director of the DC Department of Health, and joining us via video conference, Dr. Georges Benjamin, Executive Director of the American Public Health Association. And in conversation, we have Reed Wilson, the Hill's National Correspondent. Thank you.
Thank you all for being here. Oh, there we go. I'd like to thank all of our guests. Dr. Benjamin is joining us from an undisclosed location from afar. I'll let him disclose it if he so chooses. But Dr. Benjamin, I thought I'd start with you. We're talking about the future of public health here. Tell us, what do you see as the coming steps that we're going to see in the next decade and 2 decades? What is the health industry going to face in order to make American public health stronger?
Well, we'll have the same opportunity that many of your speakers spoke about earlier, using the new genetic technologies to do advanced molecular detection, so that we'll be able to tell you exactly what organism was infecting you and trace it around the world. We'll be able to have better food safety, just an absolutely amazing amount of opportunities with the technology that we have today that public health we're able to use. But I also want to emphasize that we also still need to utilize that low-tech stuff, like good hand washing and covering up your nose and mouth when you cough or sneeze, which, quite frankly, continues to be the best innovation we've ever had.
Dr. Levine?
So thank you for that question. I think that the future of public health is looking beyond the traditional definitions of health and to look at what are called the social determinants of health. So those are the other aspects of our environment that are not typically considered healthcare related, but that influence health. So that could be, of course, economic development. That could be availability of transportation, availability of affordable housing, nutrition, the environment, all of those other factors that influence health. For example, when you think of the opioid crisis, we emphasize the role that overprescribing has played, and I think that was very important. But others call the opioid crisis and the suicide crisis that we're facing now diseases of despair. And so in Pennsylvania, what are the commonalities in 2 cities that have a large amount of overdoses due to opioids? Kensington, Philadelphia, and Cambria County in Johnstown. One is rural, one is very, very urban, but it's lack of economic opportunity. So I think that we have to broaden our view of what health involves.
Dr. Nesbitt?
So I see a combination of both what Dr. Levine and Dr. Benjamin have talked about, and that's continuing to close the gap or the chasm that exists between public health and the healthcare system as being what will strengthen the future of public health, or as we sometimes talk about it, population health. So we're all working collaboratively to improve the health of the population by improving the health of the individual. Some of the things or examples that Dr. Levine gave are based on, and some of the things that we've heard from some of the other discussants and panelists already today will lead to being able to do that. So when we talk about making improvements in technology, when we talk about improving personalized medicine, using these new technologies, using new genetic improvements, all of those things help to improve what we know in healthcare, help to improve what we know in medicine. But when we do that and the individuals in the healthcare system provide that information to us in public health, we improve what we know about the overall population, and we can improve population health management. It helps us improve better overall interventions at the population level, helps us create better policies at the population level, and when we improve how we collaborate both on the public health side and how we do things on the healthcare side, we do a much better job of managing the health for our population, and we can improve the health of one community at a time.
All right. Dr. Benjamin, what changes do you want to see policymakers make? And what changes are up to sort of society at large to make to improve public health? Uh-oh. Might have lost his audio there.
There we go.
Oh, there we go. All right.
Yeah, I think we need to spend a lot more of our resources on prevention and wellness, moving way upstream to address, you've heard the issue around the social determinants of health, but also investing in data systems so we can make real-time data-driven decisions. That's one of our real challenges is the data-driven part of that. When I was in Washington, D.C. Or in Maryland practicing public health, quite too often we were making data-driven decisions based on 2-year-old data. So getting real-time data, just like the rest of the healthcare system is beginning to do, is going to be very, very important to move forward.
Would either of you like to address that, the notion of big data and how it's changed the approach to healthcare? Dr. Nesbitt.
Oh, absolutely. So this is, again, part of that better collaboration and closing the chasm between public health and healthcare. And we talk about that. I mean, we're all speaking sort of the same language, so that's great. We're all on the same page in terms of improving the future of public health. We have a commitment here in Washington, D.C. to having data-driven, outcomes-oriented approaches to policies and programs. What that means is that we've got to have better access to data. And we've been on what has probably been a slower than we would like commitment to improving access to data, both by looking at what we have access to in the clinical space, but also to how we improve access to population health information. When Dr. Levine talks about the opioid crisis in this country, if we were using traditional data methods, right, taking 2-3 years to have access to data to improve policies, programs, and initiatives, we would continue to remain behind the 8 ball. But we're getting data in real time, near real time, to improve the quality of programs and services, to make real policy changes in terms of access to harm reduction services, to improve access to the way that our healthcare providers prescribe, or changing who those healthcare professionals are, or even lay individuals in our communities who can actually reach people who are in crisis by increasing the frequency by which we have access to data and not letting perfect be the enemy of the good in terms of healthcare data and population health data for decision making.
So I would agree with my colleagues in terms of the importance of data. So for example, with the opioid crisis, Pennsylvania has a very robust data dashboard. In fact, we have now Data Dashboard 2.0, which was just released. And so we have data on our 3 pillars in terms of our response. We have data in terms of prevention, and the highlight of that would be our prescription drug monitoring program. So if you go there, you can see that opioid prescriptions in Pennsylvania have decreased 26% in the last 3 years. We have data on rescue, which involves the medication naloxone. So we have data on EMS saves. We have data on police saves. We have that by county and community. So very, very granular data. And then we have data in terms of the expansion of treatment, particularly medication-assisted treatment. A new program that we have in collaboration with the University of Pittsburgh School of Public Health, sponsored by the Aetna Foundation, are some data about community effects and looking at neonatal abstinence syndrome, looking at the effects of the opioid crisis on families. And so that's all available on our data dashboard, and that informs our strategic policy. Mm-hmm.
Let's talk about the capability to respond to sort of the 3 big buckets of public health, the chronic diseases, the long-term epidemics like the opioid epidemic that we're going through right now, and the possibility of a future global pandemic, something that hits the U.S. From whether it's homegrown or from overseas. How capable are we at the moment of fighting those 3 challenges? Let's start with the chronic side.
So we do quite a bit to monitor chronic health conditions. We do that in terms of what our ultimate responsibilities are as a state and local here in Washington, D.C., statehood, 51st state. We do that in terms of being able to work collectively with our partners. We put forth a dashboard. We have over 150 key performance indicators that we monitor on an annual basis and providing updates in terms of where we are in terms of meeting our progress. Because we are also a funder of many community-based organizations and other healthcare providers in the district, we make sure that anyone anyone who is getting funding from us can attach themselves to moving the progress on those key indicators. So that's one of the ways that we help to make progress around those chronic health conditions like heart disease, diabetes, asthma, paying attention to chronic lung disease, even brain health. We're able to work collectively as a community to set what our priorities are, where we want to be in 5 years, where we want to be in 10 years, and being able to put together very clearly for organizations, whether you are a academic health system or a community-based organization, giving you very clear, the highly sophisticated statistics or that red, yellow, green light in terms of whether we're making progress toward that goal.
So I would agree. I think that health promotion and disease prevention are critical aspects of public health. That can include, of course, maternal child health. That includes infectious diseases, includes chronic diseases, as you mentioned, whether it's obesity, heart disease, diabetes. So that's really very much the bread and butter of public health. I like that you mentioned preparedness. And so to me, one of our priorities in the Pennsylvania Department of Health will always be public health preparedness. We frequently see floods and those type of issues in Pennsylvania, but I mean preparedness for, in addition to that, to a novel illness or disease X, as the CDC calls it, that we're a plane ride away from, or something that could be the risk of something like pandemic flu. So I think it involves having the public health departments prepared in the state level, working very closely with our counties and communities, and then collaborating with the CDC and our federal partners in terms of being prepared for whatever eventuality might occur.
Mm-hmm. Dr. Benjamin, let me ask you the direct question. Are we prepared for the next global pandemic, whether it's an influenza or something else?
The short answer is no. We need to really reinvest more into our activities. We have a tendency to do what I call yo-yo funding. We put a whole lot of investment in, like we did after 9/11 and the anthrax letters, and then over time we began to de-invest. And so right now, while we have this enormous measles outbreak, for example, that you're seeing, the health departments that are handling it are struggling to do that. So we need to begin reinvesting in the workforce. Just like everybody else, we're all getting old, and we're having this transition of the workers that we need to reinvest in. But we also have to reinvest in new technologies. When we had the initial anthrax letters and 9/11, we had many health departments that had rotary phones. Most of them were just getting their first set of computers. Well, obsolescence, of course, has set in. And so we need to reinvest in all of those things. So I worry a lot about it. While we can handle one activity, handling two or three at one time, which we're continuing to have to do, climate change, a measles outbreak, and pick the next flu outbreak, we would be in trouble.
All right. Of course.
One of the things that we've done in the district is be able to look at preparedness through the lens of resilience. And we look at resilience from the perspective of shocks and stressors. And being able to look at it, through the context, we talked a little bit about social determinants of health, but recognizing that in our communities that the residents who face many of the adverse impacts of social determinants of health typically face more stressors. And when we have shocks to our community, whether they be the next emerging infection, influenza, an epidemic, or even anthrax coming to our communities, or a flood that will come to our community, those types of shocks are going to hit communities that live under more chronic stressors. So as there are some cities that are part of 100 Resilient Cities initiatives, DC happens to be one of them, we've approached our Resilient Cities concept, engaging many agencies and organizations that are part of the government and many community partners that are interested in resilience. Most of them came to it initially from a climate change perspective, being committed to helping us from an emergency preparedness and health preparedness framework, being committed to address the populations that face more chronic stressors so that when we have shocks to our community, we are in a much better position to respond.
All right. Well, let me open it up to any questions from the floor. We've got just a few minutes left. Anybody have a question for any of the three? Oh, yes, right over here. Sorry.
Thank you. This question's for anyone on the panel. I'm Jenna Wright. I'm with RTI International, and we're an applied research institution that has extensive experience with helping large payers apply value-based purchasing. And I'm very interested in comments that were made about how departments of health and even like APHA can be funders or can help synergize this movement toward better service delivery as well as public health. So I was wondering what state health departments and public health professionals in general can do to improve efficiency and outcomes of the healthcare service delivery system at the local level. Thanks.
So I'd like to take that question. So we have a large amount of rural hospitals in Pennsylvania, and rural hospitals in Pennsylvania and really throughout the nation are being significantly stressed and at risk in a traditional fee-for-service model. It's very hard if you're getting paid on a fee-for-service model in rural hospitals to have enough inpatients to be able to support that. And as they pay attention to that, they're not paying attention to the population health issues that Dr. Nesbitt had mentioned. So we have a new rural health model in Pennsylvania, which will transform rural hospitals to a global payment rate. So instead of being paid for fee-for-service, they will basically work under our tutelage with the major insurance companies for a global budget for the year, and then they will have a transformation plan to go from that fee-for-service model to a population health model. This is supported by CMMI, the Center for Medicare and Medicaid Innovation. And we have started that model. It started in January. We have 5 hospitals now working with our payers on that global budget model. We will have 18 by January 2020, and we will have 30 by January 2021. And this is a very innovative model, and we're hoping that with the success of this, that we'll be able to show that these global budget payments can be able to be one of the factors to save rural hospitals in Pennsylvania and hopefully throughout the nation.
All right, we got time for one more quick one, if anybody's got one. We saw one more over here.
Hi, my name is Victoria Laredo, and I work for Palantir Technologies. So this is a question for the entire panel. You speak about the importance of data access. I'm wondering how you're also thinking about the data's quality and accuracy and any initiatives you're taking to ensure that that is in place.
So we have embedded in our infrastructure lots of mechanisms for data quality, beginning with the types of people that we hire, who are very skilled in terms of their qualifications. We have hired many people at the doctoral level, in terms of entry level people. So we find that many of the staff in our health departments have the same level of qualifications as many people in think tanks and many research firms, et cetera. We pride ourselves on being an academic health department, and in terms of the quality of the people in our staff, they actually publish in peer-reviewed journals, and they partner with academic institutions. So that's a piece on data quality, both from the statistical analysis, doing GIS, and all of those other things. The other part of it is in terms of the types of analysis that people want to do. There's the things that you can do that are types of descriptive epi versus trying to do secondary analysis, people who want to make inferences, causality, association. We get lots of requests for this is a cancer cluster, this is a cancer cluster. Governments are asked to do those types of things all of the time, and that's a part of a lot of the communication that happens with communities is where you have to put some of those barriers up. The other things around big data, data analytics, how much data you put out for open data. We often find ourselves in a position to have to be consultants around how people who don't have backgrounds in health and public health, but who are very good as data analysts, data scientists, are making inferences around health data. So when we talk about data quality, I think the risk for the quality of how data is used increases when data comes out of healthcare organizations and state government organizations versus the risk of data quality being intrinsic to the organization.
All right. Well, Dr. Nesbitt, Dr. Levine, and Dr. Benjamin, thank you all so much for taking the time. And thank you.
Thank you.